one which many of you would have been familiar with, some may not be so familiar, systematic reviews. I'm going to talk mostly about systematic reviews of randomized controlled trials. However, I'll give you examples of different types of systematic review as well. Are they popular? A couple of days ago, I put a search on PubMed, and there are 33,000, pages, and 340,000 in PubMed alone systematic reviews. There's another database called the TRIP database, and people use the word meta-analysis sometimes for the mathematical addition of data. And there are again another 6 lakh articles in that database. So clearly, systematic reviews are increasingly popular, and it's something all of us must be familiar with. I came across this article yesterday, written by Ian Chalmers. He's a gentleman who actually set up the Cochrane collaboration, one of the many organizations which does systematic reviews. And he was writing about the history of systematic reviews. And he said in the 1720s, 3 gentlemen, James Jurin, Thomas Nettleton, and John Gasper, they looked at multiple studies and combined the results of them for effects of smallpox inoculation in England. So this has been a science which has been around for a while. This is Carl Pearson, a famous statistician, and he had written a note on the effect of typhoid inoculation across the British Empire. It combined and got a pooled estimate. Of course, this is an article from the James Lind Library on Carl Pearson's 1904 meta-analysis. R.A. Fisher, whom Dr. Kant and Dr. J. Seelan have referred, the father of modern statistics, he has written an article looking on multiple studies on agriculture and how the results of agriculture vary by location and time. So this is the design of experiments in his famous book. That includes a little bit about combining evidence from various places. The third person I want to talk about in the history is Glass. He looked at a meta-analysis of psychotherapy outcomes in studies, and I think he was among the first people to use the word meta-analysis. So this is Dr. Glass, and these are the other two. So this is a little bit about the history of systematic reviews. This is the Cochrane collaboration, and if you have internet on, you can open the website to this Cochrane library. It is the largest source of systematic reviews in the world. It's also the largest source of randomized control studies in the world. So it's a good website. Anybody can access it free from anywhere. If you want to search the full text of a Cochrane library, you can do it now during the workshop because you have access to the CMC network. Otherwise, you'll be able to access only the abstract of the Cochrane reviews. Yeah. The main important thing, which at the end of this class, if you forgot everything, there's a book called the Cochrane Handbook of Systematic Reviews of Intervention. There's a separate book for diagnosis, economics, and other things. But this is a system RCT workshop. So Cochrane Handbook for Systematic Reviews of Intervention. It's free. Anybody can just go to the website, just Google this Cochrane Reviews of Systematic, and then you can go through the step-by-step how to do the entire systematic review process. So that's an important thing that anybody can access. So I'm going to start with the story. This is my postgraduate student named Mahima Sadanshiv. And we were looking at diabetic patients in Medicine Unit 2. And Dr. J. Seelan at that time was working with us in the clinical epi and biostats department. And we randomized subjects who were staff members in CMC to get WhatsApp messages on diabetes. And there was a behavioral change process. There was a science behind how the messages, first awareness of diabetes, then awareness of taking medication, exercising, testing regularly. These are all diabetic. And the other group was standard of care, where all healthcare workers with diabetes are seen in a staff health services every 3 months. So we wanted to see, was there any effect of having this regular M-health intervention, if you like. And at the end of the study, we found that there was a difference in the hemoglobin A1C of about 0.5 in the two groups at 6 months. So this was the beginning of a journey on a randomized control study. Recently, I was looking at the same topic. In April of 2024, uh, Anke was Lewis, I'm not sure my pronunciation is right, and colleagues did a systematic review of the same topic. Systematic review means in people with diabetes, does M Health have any role in addition to the usual care? So, and then she called it diabetes self-management education. So this was the important thing that she was looking at. And what did she do? She started off with the PICO. I apologize if it's not clear. It looked at diabetes self-management education in patients with diabetes versus usual care. So that's the P is people with type 2 diabetes. The intervention is diabetes self-management education. The control is usual care. And the outcome was the hemoglobin A1C, exactly like the PICO of our randomized control study. So what did she do in her systematic review? She mentioned the PICO, patient intervention, and the study design. And she said, I only want randomized control studies which have looked at this particular question. You're getting the sort of idea like I'm building the story. She then searched all the literature in the world she could possibly search. She looked at Medline, which some people call PubMed. Embase is Ensapta Medica, or a European database. PsycInfo, Cochrane Register, which you can all search free. Clinicaltrials.gov is the US clinical trial registry. There are so many 140 countries in the world. Every country has a clinical trial registry. You cannot possibly search all 140 countries. WHO has got an international clinical trial registry, which is just a amalgamation of all the various 140 countries. So if you want to know if there's an RCT in your topic, a good place to search is the International Clinical Trials Registry portal. And then she also hand searched articles from here and there. One of the things you will find in a good systematic review, if you are going to search, for example, in Medline or PubMed, you have to say that there's PICNO. There may be different words for diabetes. So what are the words you use in your search strategy for diabetes? M Health may be called telemedicine, various other words. What words used for that? Usually we don't use any words for the comparison and outcome. So you must give what all words you use in searching for each of the databases a search strategy. So to tell the reader that I've searched as much of the world literature as possible. Other thing is many articles may be in French or German or Hindi or Tamil, and you're not supposed to exclude any article based on language. What about preprint servers? Now people are publishing in preprint at the time of COVID. You can include them. Any material anywhere in the world can be included. So how did, once they searched the articles, 4 of the authors of that paper independently, meaning they did it separately, screen the title and abstract of every single publication. So at least 2 people have to screen the abstract of every single RCT which they got. Once they screen the abstract, the next stage is looking at just the abstract to decide, I don't want this article, I want this article. If you want the article, you must get the full text of those articles which you decided looking at the abstract that is interesting for you. So you get the full text. After that, 2 people independently must look at every single full text to decide if you want to include it or exclude it. And then if you have disagreements, there's no boxing match. Senior author on the team will be the adjudicator. He'll say, yes, include or exclude. So this is the process of study selection. Coding. Remember, you're not doing a study. You're taking other people's study and putting it together for the same PICO and study design. So what information are you going to collect from every study? So that you must have a data collection form or a CRF. So you must code what all information you're trying to get. The author's name, the publication, information about the PICO, all the data you're going to collect from every paper you must have coded and kept in the beginning, HbA1c. Now, an important question, they determined based on literature that a difference of 4 millimoles was clinically relevant. So even in systematic reviews to say if your outcome is continuous, how much difference in the continuous outcome is clinically meaningful. So they did that. An important thing, Dr. Kant was mentioning that randomized control studies are not powered for harm. There's a primary efficacy outcome, which is the benefit. They also report harms. So very often harms are missed in randomized control studies. However, if you have a systematic review where you're collecting many small studies, it's a good place to start looking for harms, because for many small studies, a picture may emerge of the harms. So in systematic review, you must also include the harms of this potential intervention. Okay, now you have got a lot of articles which you decided to include. As mentioned on day one, garbage in, garbage out. You might have got randomized control studies. Yesterday, you all presented the CAS checklist. Some were slightly better, some were slightly worse, but that's from one of the top medical journals in the world, the New England Journal. But there are journals and there are thousands of journals, and RCT is published everywhere. As Vignesh mentioned from John Ioannidis' comment, almost 80% are rubbish. So you don't want to put rubbish randomized control studies in your systematic review. You want good quality systematic reviews. That is called risk of bias assessment. What is risk of bias assessment? It's exactly what you all did yesterday. Random sequence generation, allocation concealment, blinding. Can somebody tell me the difference between allocation, concealment, and blinding? Are they same? So allocation concealment is a step before the intervention starts. Very often people mistake the two and think, if the patient has an open label study, allocation could not have been concealed. No, no. It's a separate process. So you have it as a separate. Then blinding of participants, blinding of outcome assessors, loss to follow-up or attrition bias, selective reporting bias. That means there were 6 outcomes mentioned in the study protocol, but only 2 are published. Selective reporting. So all these are the things which you did in the CAS checklist. All these in systematic review, we can call it critical appraisal, but they call it risk of bias. So just to show you in a picture how it looks, you have to make an Excel spreadsheet, or you can use it in a software. The rows in the Excel spreadsheet are these 7 points are kept here, and the columns are each study. The study is listed by the first author's surname and the year of publication. So you can see that this first study, randomization had a low risk of bias. That means it was done well. And similarly, allocation, low risk. Blinding, high risk of bias means there was a problem with blinding. And what you see in orange here is not slightly in between yellow and red. It is unknown. That's because the authors did not write anything about that particular aspect in the paper. And you're supposed to write to the author. You've written randomization, but I don't know how you did randomization. Please tell me how you did. Because nowadays everybody's email is there in the articles. Suppose they don't reply, then you're forced to put unknown, right? So this is the risk of bias assessment for all the studies in this paper. Then comes data analysis. Suppose it's a continuous outcome. Now we have learned all these things in the class today. Then you do mean difference with 95% confidence interval. For dichotomous data, then they use a variation of odds ratio called the Peto's odds ratio. This I'm going to explain a little bit later. You can do these analysis by 2 methods. One is called a random effect model. One is called a fixed effect model. I'll explain that. In this particular study, they chose a random effect model. If there was missing data in the primary studies or data which the author could not extract, you're supposed to write to the author and say, I want this data. Please give this extra data to me. Sometimes the data is not available in the paper, but in the figure, from the figures in the paper, you can find out the data. 3-month mortality may be available in some figure, but not in the text. In a systematic review, much like a randomized control study, you can plan subgroup analysis. Subgroup analysis is what is planned ahead of time in systematic review. You say that, hey, this drug or this intervention may work better in men or women. Older people may not be very tech savvy, and the HbA1c at baseline, how many were more than 8 or less than 8. So you plan subgroups in advance. Sensitivity analysis in a systematic review is, we will separately look at later on studies with good randomization and poor randomization. So the conduct of the studies might not have been so good. So there may be some, we're already trying to eliminate poor studies, but even within them, there may be some slightly better quality studies and worse quality. We'll subgroup the studies like that. Generally, that's what comes as sensitivity. After you look at the data, you're planning to do an analysis. Are you all a homogeneous group of people or quite heterogeneous? The participants, heterogeneous. But we are looking for homogeneity in a systematic review. Why? We specified the PICO, we specified the study design, we threw out poor quality studies, and we kept only high quality studies. So we expect all the studies to show the same results. Variations in the results of the systematic review from each study to study is called heterogeneity. And there should be a method to capture heterogeneity. So they use the chi-square and I-square statistics. It's outcome heterogeneity, which will be explained by different things. We'll come to that. So they looked at and they said the chi-square value of 0.05 was taken. And because the number of studies were small, they changed it to 0.1. They said that if there were more than 10 studies, they would look at publication bias through something called a funnel plot. So this was what they said they're going to do. And they used a software called Review Manager 5.4.1. Now, suddenly, with the lack of funding for academia across the West now, Cochrane has been forced to a business model where you have to pay for it, and it's an online software, and you work with it on the net. And every time you use it, you have to pay for it. We have some older versions available with us. Like, what is the flow diagram in a RCT called? Consort diagram. So the flow diagram in a systematic review is called Prisma flow diagram. So remember I told you the search strategy? They searched Medline, Embase, PsycInfo, Clinical Trial Registry. From that, they got 5,000 articles. Because you're searching many databases together, you may get the same article in 2 databases. So they removed 3,000, they removed some duplicates. After removing duplicates, which must be about 2,000 articles, there are 3,000 abstracts they searched. After searching the abstracts, means 2 people independently looked at the abstract, they got rid of 3,618 articles. They were left with 239 full text to look at. Again, 2 people independently looked at this full text, and finally they said 80 articles will include. Among the 80 articles, some were ongoing trials and some didn't have enough information, so they decided to include 39 trials. Apart from these places, you can search anywhere in the world. Maybe your friend knew of a study, or one randomized control study referred to another previous randomized control study, which didn't turn up in your search strategy. There's something called gray literature. A postgraduate student does a randomized control study. He or she never publishes it. So in many Western countries, one can search thesis database. Many Indian universities also, one can now start searching the thesis database. So they got 4 more articles. So finally 43 articles, from which 42 gave enough data. This is the flow diagram. So a picture is worth 1,000 words. So this is the meat of the randomized controls, the systematic review. The next thing is they have to give you, for these 43 studies, for these 42 studies, they have to give you some data about each of the studies. That is called included studies table. If I'm going fast or slow, just put up your hand. I can go slower or faster. So for example, Abaza 2017 is the surname of the first author, and the study was done in 2017, parallel group study, outpatient setting in Egypt. What was the intervention? What was the control? How many participants? How many were women? What was the average age and the duration of diabetes? So this is some baseline information you have to collect about. I told you the coding, what information you're going to collect from every single study. And in that, I was very pleased to see that our randomized control study was also included, and they had taken it's a tertiary care hospital in India, and they are given the breakdown of our hospital data as well. This was risk of bias. So sequence generation, allocation concealment, blinding of the participant, blinding of the outcome assessors, and what you all did yesterday. And for every single study, they have given the risk of bias. In our study, the participant obviously knew whether they got a WhatsApp message or an SMS, so they were unblinded. So they have decided to call it high risk of bias. A point to make. The outcome was hemoglobin A1C. Will that measurement be changed by the participants' knowledge of their intervention? If the outcome was death, would the outcome of death be changed by the participants' knowledge of blinding? So some people will not rate hard outcomes, biochemical values. What about an X-ray? X-ray reporting is subjective. Pathology reports, little subjective. But anyway, these people have decided because it was unblinded, they put it as a high risk of bias. That's us. Now, what is the principle of meta-analysis? From study 1, there's a summary statistic, which could be odds ratio, relative risk, risk difference. It could be anything, any data, but the same outcome, the metric is the same from all the studies. So study 2, study 3, study 4. You understood that? So this is what you collect. The data you collect from each study is the odds ratio or relative risk or risk difference from each of the studies. These odds ratio, relative risk or risk difference, these are combined to give a summary measure. That is meta-analysis. Everybody clear? We don't collect the data, primary data from every study. We only collect the final summary statistic from every study. We combine them together to give a meta-analysis. So it's not a simple average. We have 4 relative risks, add all 4 and divide by 4. It's wrong. It's a weighted average. What is weighted average? Larger studies are given more weight. Studies with more events, more people died, that's given more weightage. So this average is not a simple average, it is a weighted average of relative risk or odds ratio or risk difference or whatever you want. It should be the same measure. Generally, it's the same measure. It could also be a different measure. So what do I mean by same measure, different measure? Suppose I measured weight in kilogram. All studies should have reported the outcome as weight in kilogram. Anybody from psychiatry here? So suppose we have schizophrenia. Dr. Vignesh's study took one schizophrenia scale as the outcome. Ma'am's study did another scale of schizophrenia. Then how do you combine them? There is a method of combining different scales as well. We can talk about that. There's another issue. On the same study, PICO, you could have a parallel group study, which you learned about. You could have a crossover trial or a cluster study. How do you combine the data from all of these different study designs? That you can combine them, and that is something called unit of analysis issues. There's a method of extracting the data from these trials and carefully doing that, right? This is the formula for a weighted average, and I'm not going to go into the formula, just to say that this average is not just a simple average. This methodology of doing a weighted average is called inverse variance method. And I told you, what does the weighting of a study depend on? Sample size and number of outcomes in that particular study. Okay. Now, let's make things a little more complicated, right? There are two methods of doing odds ratio or relative risk. One is called random effects model. Another one is called fixed effects model. And I'm going to just give you some names. So for the random effects model, the commonest method is called this De Simonian and Laird method or Laird method as a common method. For dichotomous outcomes, the method of doing meta-analysis, there are many. Mantel-Hansel is a very popular one. Pareto inverse variance. If the outcome is continuous, like example, weight in kilograms, and everybody measures in weight in kilograms, we use a simple mean difference. However, if the outcome for, like I gave you the example, is measured in different scales, we can use something called a standardized mean difference. If you want to look at change in scores, we can do this ANCOVA model. It is possible to combine dichotomous and continuous data as well. There are methods given for that. It's also possible to do systematic review of count data, of rates, and time to event. So any type of outcome can be combined, not combined, but you can do meta-analysis of various types of outcome. Now, I can see some of you are worried, like, where can I read this? Chapter 10 of the book, which I gave you, the link to analyzing data and undertaking meta-analysis. Everything is given there. Each of these methods in grave detail with pictures given there. I don't have time to go into the analysis of each particular type. That's almost a full workshop by itself. The next thing is heterogeneity. So any kind of variability among the studies. So one is not here or one is there. So suppose one person looked at middle-aged diabetic patients and somebody other had mostly elderly diabetic patients. Will the outcomes be same in both trials? Somebody use WhatsApp, somebody use SMS? May not be, we don't know. So you can see based on the clinical, that's called clinical diversity or clinical heterogeneity. Based on the P, I, and O or the comparison, there may be some differences in the outcome that's attributed to clinical heterogeneity. Somebody did HbA1c by HPLC method. Somebody used HbA1c by some other serological test. The accuracy of those measurements may vary from methodology to methodology. So there may be some methodological heterogeneity between the studies. The last one is called statistical heterogeneity, by the way in which the people did the analysis. I already told you there are many methods of doing odds ratio, relative risk. Some people say statistical heterogeneity is taking clinical and methodological together. But in any case, this is what explains how can the same PICO study design have different results. You have to explain it in your systematic review. How do you explain it? By thinking of these issues, looking at each paper and seeing how they are different from each other. You understood? This is called heterogeneity. There will be some differences due to chance, right? Beyond chance, how come there is differences? That is heterogeneity. So I'll show you some pictures in a few seconds. The statistical method for heterogeneity is called chi-square. Because most systematic reviews have only few studies, the power of the chi-square tends to be low. So for systematic reviews, generally the p-value is taken as 0.1 to look for heterogeneity. There's another one called I-square statistics. Again, if I show you pictures, it will be more enlightening. And this I-square is interpreted like this. 0 to 40, little heterogeneity. There's a little overlap here. 30 to 60, moderate. 50 to 90, substantial. 75 to 100, considerable heterogeneity. So this is a way of, I'll show you the pictures, then it'll be easier. Okay. Let me show you the picture first, and then I'll explain. So DSME was the intervention versus no intervention. These are diabetic patients. And each of this, let me explain this picture to you. This is experimental, meaning the DSME arm. Control is nothing. Each of these names is the name of one study. So how many are there? 1, 2, 3, 4, 5. 5 studies in this meta-analysis. This is our Sadan Shift 2020. Not the year she did the study, but the year the study was published. In the experimental arm, there were the mean HbA1c was 7.28. The standard deviation was so much. We had 161 patients. In the control arm, it was 7.31, standard deviation, a total number. And for each study, you read it like that. The outcome here is mean difference in the HbA1c between the two. A mean difference of 0 is this line, mean difference of 0. So the null effect in a systematic review depends on the outcome measure. If you're looking at the difference between two variables, difference of 0 means there is no difference. Your weight and my weight are same, the difference will be 0. What about for relative risk? Your risk and her risk are same. 1. Odds ratio? 1. So this line of no difference in a meta-analysis plot is 0 for mean difference. It means 1 for odds ratio and relative risk. This is our study data, which was bang on 1 and was crossing both sides of 1. You can see that some studies are here, some studies are here. This is the final summary diamond. This is a meta-analyzed report. Did they simply add up the mean differences and divide by 5? No, they did a weighted mean. So you can see one column here called weights, right? So these are the weights given for different studies. I'll explain that in a subsequent slide. Did they use fixed effects or random effects? Here you can see inverse variance method, random effects. So you have to specify each of these things. Can somebody see where the chi-square value is? So you can see the chi-square value, degree of freedom, and p-value is 0.06. You can see the I-square value, 53. So moderate heterogeneity. And you can see also that if this was called a fixed effects model, in a fixed effects model, larger studies, for example, Kerfoot 2017 had 200 and 200 patients. He would have got about 50% of the weight. Our study would have got about 30%, and everybody else would have got much lower weight. Fixed effects model penalizes smaller studies and favors larger studies with more events. A random effects model, we'll come to that, gives almost equal weightage to all studies. It's more of a philosophy. If you think that, hey, there's only one truth in the world, you generally go by a fixed effects model. If you think that every study is telling the truth, I'm simply combining them together, you go for a fixed effects model. You'll see one more number here. I know it's a bit confusing if you're doing for the first time, tau square. If you see tau square, it means it's a random effects model. I will explain this again. So this is the final subtotal for this particular outcome, looking at DSME alone. Now, I'm a bit concerned that this heterogeneity is big. So I want to see how I can explain it. So one of the methods of explaining heterogeneity is to do what is called subgroup analysis. There were 3 different kinds of M health. One was called DSME, one was called DSMS, and one where they had combined both together. If you look at everything together, you can see that in the bottom here, I don't know if the people in the back can see, the overall heterogeneity was about 50%. It's a bit high. So people thought, why not I subgroup the 3, DSME, DSMS, and DSME or S. I-square was 53% in the DSME group. I-square was 53% here and only 21% here. So all the heterogeneity is not explained fully by this particular subgrouping of results. So one of the ways of explaining heterogeneity is to do a subgroup analysis. I hope I've not lost anybody. This is the subgroup analysis. Each of these summary diamonds is a summary diamond for that particular subgroup. Any questions? Because this is the meat of a systematic review data presentation. Yeah. So this is totally, if you add all the weights together, it will come to 100% weight. One more thing which I'm not touching on, but I think is important. How many patients were there in this whole systematic review? This is the total number of patients here: 683, 665, 3215. So it's like 3215 in intervention, 3149 in control. So there's a reasonable amount of information in the systematic review. Some systematic review will be 4 small studies. Total number of participants will be only 300. Then don't sell your soul on that systematic review because the information was low. You should imagine if I did one single large randomized control study, what would have been the adequate sample size? Then I would have wanted about 4,000 in each arm. Hey, we got 3,500. Okay, I'm not too worried. I can believe these results. If I got only 200 people finally in a systematic review, despite there being 4 studies, I'm still unhappy with the results.
How does it take care of the implementation of intervention? Because they may be.
No, this method is only the mathematical combination. If you find that one study did health, another study did phone call, a third study went to the person's house, you should not have combined them in the first place. The decision to combine is looking at the paper and the researcher deciding that the interventions are similar enough so I can combine. This will not show up this.
It may be a same drug, but the way it is being given to the patients, there may be a slight changes in the protocol, the way it has to be implemented.
So you can look at that in subgroup analysis. But again, biologically, you must decide is it worth combining them or not. That's it. Doctor's decision. Okay. Well, those of you are not confused already, here's a little confusion. The hand mic? Okay. That's the hand mic. This is called the fixed effects model. This is the summary effect of all the studies together. And this is the effect of a single study. All studies put together, this is one, and this is the effect of one study. And each study is penalized by an error term. That means there's only one single effect, and the variation of each study from that final effect is the error. In a random effects model, each study has got its own effect, and there's a final effect. So now there are two variations. The variation from the study to the final mean and the variation between studies. You're accounting for both of them. You're not saying there's only one effect. All studies are telling some sort of truth. We are forcing them together to give one final estimate, which is very much like this. So in addition to this, there's also a variation between studies. So the random effects model looks at the variation between studies and the variation from the final averaged mean. Right? That's a fixed effects model and a random effects model. Okay. Conceptually, the fixed effects model estimates in the studies, it assumes all studies should say the same thing. Where the random effects model assumes different effects across different studies. As I told you, the variation is only from within the study to the final estimate. Whereas in a random effects model, variance is derived from both within the study and between studies. As a result, the confidence interval for fixed effects is generally narrow. Confidence interval for random effects model is generally wider. What is the practical consideration? If you have large studies, fixed effects models tend to give them much larger weight, whereas in a random effects model, they don't penalize small studies that much, and they don't give that much benefit to larger studies. Which one is the best method? Previously, they'll say that you must specify it before, based on your understanding of biology. Hey, this is an outcome which tends to vary. Let us use fixed effects. Then it used to be on the expert in the group. Our Cochrane group only does fixed effects. Our Cochrane does random effects. Currently, people say do both. Report both. If both say the same thing, no worries. If both say different things, hello,
there's a big problem. Just based on clicking one button in a software, I can make an intervention appear good or bad. Then you warn the reader that these results are not very robust. Or I can choose, I can keep on trying out various methods till I get a p-value which I want. So that's not something to be done. You must report both. Okay, now look at this. Is it very homogeneous results? These are the three studies, ASCOT, BPLA, ELSA. How do you make out homogeneity? If the confidence intervals overlap, we are not too worried. The confidence intervals overlap. This is the fixed effects. This is a random effects outcome. Both are almost the same. So you're not very worried. And the I-square value here is 0. Look at this one. Is there heterogeneity? See, this study is all the way here. This study is all the way here. But to some extent, all the confidence intervals are overlapping. The I-square value is 45. You can see the fixed effects gives a much narrower confidence interval. That's the point estimate in the middle of this diamond. And that's the confidence interval. So that's the point estimate and that's the confidence interval. Random effects, much wider confidence interval. Fixed effects, narrower confidence interval. Now look at this. Are the confidence intervals overlapping? No, they are just barely overlapping. Here the I-square value became 59%. Here you can see the fixed effects model is here, point estimate is here, whereas the random effects point estimate is there. So a lot of things vary. So you must get used to looking at these two things. Now, some more mathematics, ideal post-lunch after some nice rice and sambar and payasam. Extra last dose of diazepam. Suppose there are, suppose you look at the studies and as he said, just give the drug orally, somebody else gave the aspirin rectally, somebody else gave IV, same dose, but I'm a bit unhappy. There are some differences. Suppose you did a systematic review and you found some baseline differences. What would you do, ma'am? You can abandon the systematic review and try and take a big hole and jump inside, or some adjustment. That's called regression analysis. The same way, if you find heterogeneity which you can't explain, there is a statistical technique of regression in systematic reviews that is called meta-regression. So here is a study looking at protein supplementation. Now, if you go to all the hostels nowadays, everybody's got, creatinine, algae, protein, this and that. All the young men want to look beefed up. After some time, you give up. So, in addition to exercise, does protein supplement? Job is looking like, sir, come home, like I'll show you my six-pack. Okay, so this is the effect of protein supplementation in addition to training at the lean body mass or the lean muscle mass, whatever. They've divided into two groups. If the exercise was done on a trained group of people or untrained group of people. And they found that overall it's favoring protein, meaning your lean body mass increased if you took the protein supplementation. But then there were a lot of baseline differences in these studies. So they said, what we are going to do is something called a meta-regression. And then they looked at baseline protein intake, protein dose, age, training status. So this is your question. So can we look at those baseline variables and put it into the differences here? We can, and this is an example of what is called a meta-regression. It's a bit advanced, so we're not going to spend too much time on it. But they also gave a nice picture which is easily interpretable. This is called a segmental linear regression. So this is the protein intake, and this is your change in your fat-free mass. And they were trying to show that there is a point at which around 1.6 grams per kilogram protein intake, where there's an inflection point. So up to that, you can increase your muscle mass. More than that, you're just expensive waste. So that's the way this kind of meta-regression plots are presented. Yeah. Okay. Now going back to the systematic review, they also looked at hypoglycemic episodes. I told you must also look for harm. All systematic reviews should have a harm outcome. So, oops, what happened to this? Okay. They looked at medication adherence, positive impact on systolic blood pressure. So there were no serious adverse events in any of the trials. 87% of patient important outcomes, can you look at? Yes, 87% of the patients were happy with the mHealth. I don't think anybody is very pleased to get phone calls on your mobile or landline. This is an advertisement for so-and-so, or do you want to invest in this? So you have to look at these mHealth interventions that patients' unhappiness with messages also is a harmful outcome. They were quite satisfied. What about cost? It costs money to send an SMS or a WhatsApp message. And only one of the 5 studies looked at cost effectiveness and felt it was cost effective. What about the quality of the evidence? So they felt that, okay, let me just give a background. Suppose you have a very wonderful outcome, odds ratio 0.5, relative risk 0.5. Everybody will be happy. What if the quality of the studies was poor, high risk of bias? Should you not warn the reader or the policymaker? So in the discussion section of your systematic review, you must say, yes, we got a very good odds ratio or relative risk. However, the quality of the studies or risk of bias was high. Therefore, I will interpret my results with caution or with a pinch of salt, or be careful. Don't directly jump and change your policy. That is looking at the quality of the evidence. Going on. So they have mentioned that the quality of the studies was reasonable. The next thing, agreement with other reviews. Now, according to one joke, there are more systematic reviews of COVID than randomized control studies. It's true, because during COVID, everybody was sitting at home and nothing to do, can't do study. Let me do systematic review. On the same topic, there are 5 or 6 systematic reviews, and most of them were junk. Yeah, really, they were really junk. And then systematic review got a bad name. Like, so now people are, oh, you're one of those guys tomorrow sitting at home and creating papers, like nothing else to do. So, but if you find good systematic reviews on your same topic, you should say whether you got similar results to them or different results. If you got different, you have to explain why your review found different results from the current review. So they have given some explanation. We don't have to go into that. Sorry. They've given a Cochrane review done prior to this found something else. Another scoping review found something else. And they summarized that HbA1c was reasonably decreased. At the end of your systematic review, you must also give implication for practice. Now, Cochrane reviews do not advocate policy change. That's the job of the policy maker. So be very careful when somebody tells you, at the end of my study, I feel all of you must start doing this. Hey, this SMS, WhatsApp may not be available in your country. And how can I say you must do? We can suggest this seems like a reasonable, cost-effective alternative. So you can give some recommendations. Implication for practice. The last one is called implication for research. In fact, according to Lancet, anybody doing a systematic review, in the introduction section, they have to give a justification from a systematic review that the answer to this question is truly not known. What is that called? Equipoise. You can't say there is equipoise. No. Have you systematically studied the literature on this topic and found equipoise? Lancet, in fact, goes to say if there is no systematic review, we encourage authors to do a review of them by themselves, show equipoise, then only undertake the randomized control study. So it's very important when you finish your review, you can say that there were only 5 poor quality studies. This is a very important area for a randomized control study with this P, this I, this C, this O, and this study design. So one good place if your postgraduate students are looking for studies to do, let them look at a systematic review. If it's a well-written one, there'll be almost a ready-made study given for them there. Implications for research. Okay, so systematic reviews are very good for gathering information summarizing the information, presenting the information, interpreting it, and reporting it. Why is it so good? Because there's a clear objective. You're clear what you're going to do in the beginning. There's eligibility criteria. Eligibility is not about the patients, what type of studies and design. Can I reproduce the search strategy? Will I get the same search strategy as them? From that time to that time, if I had searched, now there may be more studies, but so it's a reproducible search strategy. Assessment of validity, because two people are independently doing, we think it is going to be correctly done. And the synthesis and presentation is standard. That's why it's called systematic review. What many people do, just listen carefully to this, even if you're sleepy. I know 4 studies in the area. I'll take those 4 studies and combine them together and say this is systematic review. Combining many studies together is called meta-analysis. Suppose you find 4 studies in a very good area, same PICU, but the context is different. One was rural Africa, one was in Canada, one was in Aborigines in Africa, in Australia, one was Eskimos. It may not make sense to combine them together. So you'll do a systematic review and you'll end it with what is called narrative synthesis. You'll report the results of all 4 studies and you'll tell the reader, hey, I could have done a meta-analysis, but it doesn't make any sense. It's like combining apple and orange and getting fruit salad. That's a joke people say. So if you're going to do meta-analysis, you must become convinced yourself that having done a systematic review, the studies are similar, therefore I did meta-analysis. Many people simply collect for the first 4 studies they get, do a meta-analysis and say, I did a systematic review. That's wrong. It will mislead the people. Now, in my specialty, I mean, Vignesh and me are clearly biased towards New England Journal of Medicine. So this is a recent review article written by a famous author on acute leukemia. He was invited to write the article. He happened to be an expert. He gave everything from the history of leukemia, clinical features, lab diagnosis, management, and future. Yes.
There's a credibility saying that they did not adhere to the protocol properly, and
that is the risk of bias. Okay, that's 2 answers to the question. Suppose the study was not done properly. How do you know? So when you're doing a risk of bias assessment, you're expected to take the protocol of the paper, check everything according to protocol, have they done. If there were serious protocol violations, then you can exclude the study, but you have to give a clear reason. Hey, this is a randomized control study which you thought. Why did you exclude? I didn't show that table of excluded studies. That means randomized control studies with the same PICO. For some reason, you chose to exclude. Now what is happening is we suddenly find there are many fraudulent trials. They write it up beautifully. Later on, you find that, and during COVID, we had this, shame to Indians, like they did a lot of studies on chloroquine. We don't want to shoot ourselves in the foot today, but many of the studies were withdrawn. What happened if that study was included in a systematic review? They have to go back and withdraw the article. Very often you'll find that when you're doing a systematic review, you're going to go through that randomized control study in more details than the author himself. Then you will find many mistakes. Now, is it your job to report to the editor of the journal and say there's a mistake? Generally not. But you'll have to explain somewhere cautiously why you chose not to include the article. It happens very often now. Very often in this expert review articles, there is no methodology section. The expert simply wrote the article. He just sat down and wrote whatever he thought. That's one major problem with the expert opinion. This picture should have come a little bit earlier. I was just searching for it. Anybody knows what this is? Funnel plot. Okay, so you all are very familiar with this. So that's the summary estimate from all the studies together. And this is the odds ratio in a log scale so that there'll be 0 there and then 1, -1 and such like that. And that's standard error or precision. One could also imagine in colloquial words as a sample size. Each dot represents a study, okay? The dark blue dots. So these are large studies and these are small studies. These studies are close to the summary estimate. These studies are further away from the summary estimate. If you ignore these white dots, what do you notice about this Christmas tree or Ashoka tree? We notice that small studies on this side of the odds ratio are missing. There must have been small studies done in the world which had slightly different outcomes. Either they're unpublished or you didn't find them. They're published and you didn't find. Or not done. That's called publication bias. So one thing which you can do is you have to report this funnel plot. A rule of thumb, everything has become a rule of thumb. Only if there are 10 studies, you can make a plot, because otherwise the plot will be anyway too sparsely populated. So if you have more than 10 studies, they address you this. But I may agree that the tree looks very symmetrical. You may not agree. So there are 3 or 4 statistical methods. The most popular one is called Egger, E-G-G-E-R, Egger's method to look for publication bias. This particular study didn't produce a funnel plot. I just wanted to show you that. This one. No, that is an estimate line. Here, this one. That's a estimate line, a confidence interval line. Okay. This is a odds ratio, log odds ratio of one, log odds ratio of one line, that one. But because you put log, you're trying to get 0 in the middle and log on both sides, 1 plus 1 minus 1. That is +1 line. Okay. Many people will do meta-analysis outside systematic review. I don't want to go to the slides now, but that is dangerous. You must always do the full steps of systematic review, then do the meta-analysis. Meta-analysis can one author do? Many people are doing. How can 2 people independently, I and me, screen the studies, me and myself, explore studies? So problem. So minimum of 2 people. One, obviously you must be interested in the topic. Second, you must be a methodology expert. So, I mean, from my childhood, I grew up reading strange books. This was Asterix, one of my favorite comics, written by Goscinny and others also. 2 authors. What is dangerous? Non-systematic review, like I showed you the picture earlier, one single expert. Tintin was also a famous comic of my childhood. I mean, and there was an author called Herge, or I'm not sure how you pronounce it. It's Herge or Herge, Herge. So now, if you find a systematic review written by one person, think of it as a comic book. So, study protocol. Always look for a published study protocol. Where do you register systematic review protocol? Prospero. If you're a Cochrane author, if you register in Cochrane, automatically you'll get a Prospero number. Prospero has become very finicky, and during COVID, there were too many systematic reviews that they said it'll take 3 to 4 months to register. There are some more agencies, you know them? In Australia called Joanna Briggs Institute. But to register a protocol, you have to undergo the training with them. Then only you can register. There's one called Open Science Foundation, OSF, you heard? It's a website, you can do OSF, you can register on OSF, and you can register trials. But if you see a systematic review without a registered protocol, big red flag. That means you can do whatever you like, keep changing your idea. Like a protocol, like Dr. Khan said for RCT, there's a protocol for systematic review which has to be registered. Only then the systematic review should start. And you have to follow it like the Bible like. And if you want to change it, you have to write and change the protocol, then only make change. It's a generally no. Because you have seen the results and you're trying to change your protocol. That's why I spend a lot of time developing the protocol of your systematic review. So for example, this is a protocol published in the Cochrane Library, a protocol laparoscopic repair for pediatric inguinal hernia. This whole document of 10 pages was just the protocol. So in their protocol, they mention the type of participants, type of intervention, type of outcome, what is the primary outcome, what is the secondary outcome. They even had a good, clear search strategy. They said they're going to search Cochrane Library, Medline, Embase, WHO Clinical Trial Registry, US clinicaltrial.gov, other sources, how they will search, electronic searches, hand searching. Are they going to use selection criteria? Are they going to use randomized control studies or not? Non-systematic review, the author will use information from case control, cohort, his own experience, case series. That's not ideal. Here they have said in this review, they will consider only RCTs. What are quasi-RCT? We never talked about that, quasi-RCTs. Cohort studies where one arm got metformin, one got glibenclamide. This so happened and followed up also as a cohort study. Quasi-randomized is people use the word randomized. Everybody came on Monday, got metformin. Monday, Wednesday, Friday got metformin. Tuesday, Thursday, Saturday got. It's not truly randomized. So very often people use the word randomized, but either you can't make out or they've done some like a non-random methodology. Why would you choose quasi-RCTs in your study, in your systematic review, if they're so bad? Some people argue, in my specialty, there are only 4 RCTs, I know them. One of them happens to be quasi-RCT. So I will present the results of all 4 studies. Then I'll give you a sensitivity analysis of the good randomized control studies separately and the quasi. If all show the same thing, I'm happy. Usually what you'll find, the good quality studies will not show any difference. The quasi-RCT, the poorly done ones will show a great difference. That's what usually happens. Okay. Risk of bias, we have gone through this. I'm not going to spend time on that. Randomization, deviation, missing outcome, outcome measurement, reported results, all 5 domains. So at the end of it, they would say low risk of bias, some concern or high risk of bias. So that's one thing I noticed yesterday. Everybody, we are encouraged not to give a score 5 on 10 for the study or 6 on 10, but one could also conclude a low risk of bias. That means the results can be believed. Some concern means maybe I'll take the results with a pinch of salt. High risk of bias means I won't believe the results at all. So that's another way of presenting the risk of bias. They have mentioned in that study, we will do a subgroup and investigate heterogeneity. We will do a sensitivity analysis based on the risk of bias. Sensitivity means looking at the quality of the studies and subdividing them. And we'll do something called a summary of findings table. And we'll use something called a grade approach. Is anybody here familiar with the grade approach? 1 or 2 of you are familiar with the grade approach. So I'm going to just teach a little bit about the grade approach. This is a free software. All of you can download it. Just Google Grade Pro and you can download this software. I cannot teach you how to do Grade Pro today, but it's a free software for anyone to use, Grade Pro. And half the world uses Grade for grading the quality of the evidence. Other people don't use it, but in Cochrane they use Grade. If you open the Grade Pro, you will come to this Grade Pro book. It teaches you all about grade. So the first thing it looks at is limitations in the design and execution of the randomized trial. What are the limitations in conducting a randomized trial? Randomization, allocation, all the things we mentioned till now, all are put together as low risk, moderate risk, or high risk. The next thing it looks for is inconsistency. Can somebody tell me inconsistency? One study shows benefit, one study shows harm. Heterogeneity. If there's significant heterogeneity, we will downgrade the quality of the evidence. What is imprecision? The width of the final confidence interval. Very good. Dissemination bias, publication bias. So putting all these three things together, or all four of them together, we will grade the quality of evidence as high quality evidence, grade quality of evidence. Who takes the grade table? Policy makers, administrators take the grade table and say, oh, high quality evidence. Then we can change our practice. Low quality evidence, we won't change. Moderate quality, you're sort of sitting in between. This is just a 1 minute snapshot of grade. You must read more about grade. Now, yesterday, Dr. Vignesh taught you CASP checklist. Now, for systematic reviews, if you want to do a critical appraisal, world over, people are using this checklist, which I put up. It's called AMSTA 2 checklist, AMSTA. Again, the AMSTA is a abbreviation of many things. And you can just read this AMSTA 2 checklist. Okay. When I was a postgraduate student, every postmenopausal woman was given hormones. Whether they had postmenopausal symptoms or not, like getting up in the morning drinking, postmenopausal, give hormones. Because many observation studies found that postmenopausal women who took hormones, less cardiovascular mortality, less cancer, less dementia, and everything was a magical drug. It's like God forgot to continue this important activity, so postmenopausal hormones. And systematic review of observation studies clearly showed it was beneficial. I don't know for what reason, the logic. The NIH did the world's, at that time, one of the largest clinical trials, Women's Health Initiative trial. 10,000 women in each arm, postmenopausal, got hormones. And the results? Increased mortality, increased cancer, increased venous thrombosis, exact opposite. Then people said, hey, all you Cochrane fellows, systematic review guys, one single large RCT is worth many small systematic articles put together in a systematic review. There's always a big debate about whether one single large RCT is better than, I'm sure Dr. Yusuf will think one of his mega trials is better than many small RCTs done here and there, right? But you need time and expertise. That's the most important thing. If you're going to do a single large study for both or doing a systematic review, you need time and expertise. If you're doing a systematic review, the time and expertise is for doing the review. You don't have to conduct any study. There's no writing up a study, recruiting patients, following them up, DSMB, nothing. Everything is done by somebody else. So some people argue this is armchair research. But if you go through all the steps, it's quite a tedious and rewarding experience. So Cochrane, why people think Cochrane? Of course, because I'm in Cochrane, I'll say Cochrane. In 2022, of 251 WHO guidelines, majority of them have quoted systematic reviews from Cochrane. So most international guidelines in health, almost all of them will have at least one Cochrane systematic review quoted in them. So 76% of new guidelines issued by Cochrane from 2021 have Cochrane reviews in them. COVID guidelines, 13 of the WHO guidelines on COVID included Cochrane systematic reviews. So it is a good thing. If you do a good quality systematic review, you can change policy. If you can change WHO policy, global policy will change. So the impact of doing a good systematic review is tremendous. I'm just trying to say it's worth putting in that hard work to get a good quality systematic review across. Cochrane has now got a funding crunch, so they're not very easy to get into Cochrane. So most Cochrane authors themselves are doing non-Cochrane reviews because the Cochrane group won't respond and this and that. So I'm not saying you must do, but use the methodology by Cochrane. So anybody here treats TB patients? Other couple of you. DOTS therapy is good. DOTS therapy means if you have TB, I'll come every morning, say like a small child, put the tablet in your mouth, make you drink water and swallow it. Directly observe treatment. So everybody said, very good, very good. So almost all countries in the world invested billions of dollars to make sure that every single TB patient had a DOTS provider. Then came a Cochrane systematic review, which was published by got Jimmy Walmink and some other people. And they found that overall, there is no benefit in directly observed treatment versus the patient taking the medicine by themselves. There was some heterogeneity. This caused a big stink for Cochrane because by the time the governments had introduced a lot of money into the DOTS program based on expert opinion. And here comes another group of experts suddenly saying all that money is gone to waste. So some people said it increased confusion, but other countries stopped the DOTS program immediately. It resolved inconsistency because one study showed benefit, another study showed harm, but overall it found no benefit. And governments were quite convinced that, okay, I think we can abandon the DOTS therapy. Of course, this is a political charged issue, so that's a bit. Systematic reviews can resolve inconsistencies. Oops, something else. Okay. Now, this is a topic which I was involved in, nutritional supplements for TB patients. Now, this is another hot topic. TB patients look thin and emaciated. Along with medicine, give them some food. So this is a systematic review we did, and we found that there is no evidence to support giving either micronutrients or macronutrients for people with TB. And TB groups are very angry, like, hey, these people are emaciated and poor, like, how dare you say this? So sometimes it can work against you or for you, but your job is to do the review, report the results. We did not say that all governments must immediately stop giving food for poor TB patients, but it was a gap in research. We found that there was no good high quality studies because you're going to find only small differences. Then you must do 10,000, 20,000 people. And then is it really looking for 1% difference? Is it worthwhile or not? So we identified certain gaps. So we wrote implications for practice, implications for research, right? So these are areas where you can make a difference. Fully answered questions. Have you ever thought of an area where we should stop doing research? Anybody can answer? A field. The benefit of statin. No need to do some more studies. India is the godfather of doing serological tests for TB. Every lab will say ELISA positive for TB. Nobody knows what it means. So at one point, WHO got worried that most doctors in India were treating TB patients not based on sputum test or any other test, but just on ELISA tests. So WHO commissioned a diagnostic systematic review on the value of antibody or antigen tests for tuberculosis. This is a famous researcher, Karen Steingart. Madhukar Pai, I think, is from Canada, but not from McMaster. He's from some other university there. And finally, they came to the conclusion that the quality of the evidence is very low. So WHO made a grade recommendation. They made a strong recommendation. Thou shalt not do antigen antibody tests for tuberculosis. Of course, people may still do some studies here and there, but WHO has said, based on high quality evidence, it's a useless field. Let us not go down that track, choose some other track for improving diet. So you can actually stop some bad practices if you do a good systematic review. Explore the differences between, anybody smokes here? What a bad question to ask. So sometimes you'll find, like he asked a question, the slight differences in the use of the drug. Can you explore that? So nicotine is a very useful supplement, or not supplement, a treatment given for people with tobacco addiction or smoking addiction. So you can see that some people are called high dependency smokers, some are called low dependency smokers. The overall I-square combining both groups together was a little bit high, 63%. What happens if you do a subgroup analysis? In high dependency smokers, clearly 4 mg nicotine gum was very effective, whereas in low dependency smokers, it didn't seem to show any benefit. So here we can see that there are differences, and therefore when we make a policy, we may say that in people with high dependency smoking, probably this 4 mg nicotine gum should be given. So we can use to explore differences and then make some policy recommendations. Okay, now this is a bit of a busy slide. It's taken from this Oxford Evidence-Based Medicine Center. Some famous people are there. There's Ian Chalmers and other people. What it's basically saying is, suppose you had a question of long-term outcome. What study design would you choose? Sorry, excuse me, prognosis. What is the study you would do? The long-term outcome of patients with COVID. A cohort study. You're following up people for a long time. What is better than one cohort study? Exactly, a systematic review of many good quality cohort studies. So the level one, suppose your question is one of prognosis, what will happen, or what, where is it? Okay, this is not here in this. Or what will happen if you do if you do a therapy? Oh, here we got inception cohort. So we have the level 2 evidence is a single cohort. Level 1 evidence is systematic review of cohort studies. For treatment, what's the best study design? That's our workshop, RCT. What is better than a single RCT? For diagnosing tuberculosis, what's the best study? A single cross-sectional study. Even better than that, systematic review of many. So they're saying that the ideal study design is one RCT, but even better than that is a well-done systematic review of well-done RCTs. You may do a very good systematic review and find only poor quality studies, right? So this is called levels of evidence. It's a famous table which was produced by this group, and it's called the Oxford Levels of Evidence, and many people quote this very widely. So what we have described so far is one type of systematic review. I've gone to some universities where the postgraduate student have to do something called library dissertation. Have you all heard of that? So they have to do one study. A separate one is how to summarize the evidence on a particular topic. A separate topic. So they'll go to the library, all the textbooks, journals, and then they'll make a written summary. We were just making a joke over lunchtime. Now with ChatGPT, probably in 3 minutes or 3 seconds, one can write a full library dissertation. So if you want to summarize all the evidence on a topic, one can do a literature review using Cochrane methods. Like an umbrella study, what's an umbrella systematic review? On typhoid, there may be systematic review of diagnosis, prognosis, therapy. You can combine all of them together and call it an umbrella systematic review, putting all the evidence from various different types. What's a scoping review? It's also looking like, it's called a gap analysis. Hey, what is the current scope? What is looking at, for example, we did a scoping review on primary healthcare in India on telemedicine. Some government of India asks, is there any role for telemedicine in primary healthcare? Because so many patients don't have primary healthcare access. Then they ask, what is the current scope? What is the current literature on it? Are there any case reports? Are there any cross-sectional studies, case control studies, RCTs? Give us the body of evidence and where there are gaps. That's called a scoping review. During COVID, this was very popular. Rapid review. In the whole process, which I told you, what takes a lot of time? Making a PICO, choosing a study design, searching all world literature, 2 people independently screening abstracts, then 2 people full text, 2 people independently extracting data, doing risk of bias on all the papers, which takes a lot of time. So what they did, rapid review, each person had their own definition. We only searched PubMed and Cochrane. Why? There's a lot of time to search others. We don't have that time. Emergency results. Then only one person extracted data. We did not do risk of bias assessment. Good or bad? But they said in rapid review, it's all accepted. Each person has got a definition of their own rapid review. It's only in a pandemic or a real emergency one should change your practice based on a rapid review. We'll come to a living review at the end of this talk because that led to a big furor about this. They're also called expedited reviews. Should we give counseling for all students who are depressed? How do people feel? Why do students bunk class? Can we do a randomized control study? Those are called qualitative studies if you want to explore why people behave in a certain way. Is there stigma around TB, HIV, STDs? Yes. So people have done qualitative studies. What's better than a single qualitative study? Systematic review of qualitative studies. So many WHO guidelines do, in addition to systematic review of RCT, they will also have in their guidelines systematic review of qualitative studies, and they put both together. One is looking at people's feelings and emotions, one is looking at the evidence, and the best one is the combination of both. So one can do a systematic review of qualitative studies. You can do a mixed method systematic review where there's some qualitative component and quantitative component. And as I told you earlier, can we do systematic review of animal studies? Very often people, when they give the talk, get very mad. I'm from anatomy, physiology, biochemistry. My wife is from micro. She said, oh, all chimma, pico, what is that? Nothing there in microbiology. I'm making fun. Please don't tell her I said all that. So we can do systematic review of animal studies or lab studies. Observation studies, cohort, case control. Economic studies, can we do? Yes. Do you know any organization which focuses on economic studies and social aspects? Is other than Dr. Kant, is road traffic accident a big problem in India? You think so? So should we improve the roads or make sure all two-wheelers wear helmet? You don't have a choice. Money is limited. Can we do a randomized control study? Or can we do a systematic review of observational studies? It's health related, but slightly different. How do we reduce crime? How do we What policy will reduce crime? Education, strict policing, severe punishment. So there's an organization called Campbell Collaboration, much like the Cochrane Collaboration. They focus on these aspects, economic aspects, social aspects, engineering aspects, better road, helmets. So if you're interested in that, you can Google and look up those economic and qualitative studies. Okay, I've repeated some of those things there. Just to give an example, always, as Dr. Khan said, before a randomized control study of a new drug, there would have been animal studies, phase 1 studies, phase 2 studies. Animal studies would have looked at a new molecule and tried it on an animal, of course, with the required ethical guidelines and safety. What's better than one animal study? Many animal studies. This is a systematic review of looking at the role of histone deacetylases in ischemic stroke. It's just to show you that you can do systematic review of animal studies. Intervention studies, the new flavor of the month is SGL2 inhibitors for all conditions in the world. And it shows that it's like, at one time they were saying that you go to McDonald's, you eat your burger, then you eat your statin, like, whether you have high cholesterol or not. So now all diabetics, non-diabetics, everybody should be on this SGL2 inhibitor. So for treatment, one can do systematic reviews. For diagnosis, how do we do systematic reviews? What is the output of a diagnostic study? Any lab people here? Sensitivity. So we have one diagnostic study, we have many diagnostic study. We can combine all of them and give a combined sensitivity. And so this is an outcome here. Molecular tests for children, babies, very small babies with infection. We want a quick diagnosis because the baby may be dead by the time the culture report comes. So here we've got a combined sensitivity, combined specificity from all studies. They will also give you the true positive, true negative, false positive, false negative. And then they will also tell you, very important, does the pre-test probability affect the positive predictive value, negative? I don't know if I'm digressing completely from this workshop. If you do diagnostics tests, you know that there's sensitivity, specificity, positive predictive value, negative. They very largely depend on the prevalence of the disease in the place. So the Cochrane review will also give, if the pre-test probability is 1%, 20% or 40%, how these results will vary. The Cochrane review will also tell you the grade of evidence, low. Right. So all these are together given in a diagnostic systematic review. Okay. Next, prognosis. Very often there are people with a single seizure in their life. As a child, they had fever, they had seizures. Lifelong, they are on anti-epileptic drugs. Some people say a person with a single seizure need not be given any medication at all. Wait for them to have a second episode. That's a bit scary, you know. You're driving somewhere and suddenly you have one more seizure. Like, when you have an accident, who do you blame? Like, so that's a prognosis study. And this is the result of the prognosis study. And this is the recurrence, proportion of people with recurrence. So what's the answer? 27% of people will have a recurrence. What is this A, B, C, D, E? Risk of bias. But this is a risk of bias for a cohort study. Like we did CAS checklist for RCT, there is a risk of bias, or there are many biases potential in a cohort study. And generally the same color scheme. Green means good, yellow means not known, red is bad. So you must look at the evidence and the, what is heterogeneity in this graph? 93%. So you will have to report that, yes, about 27% of people with a single episode of seizure will have a recurrent seizure. The quality of the evidence overall appears to be, let's say, moderate, but there's significant heterogeneity in these results. Yeah, that's how one will word the answer. Yep. No. How can you have randomized in a cohort study? Okay, I'm just digressing, but simple, most important, how was the cohort assembled? Did you take your convenience sample of you and your friends, or did you do a random selection from the whole population? How was the exposure verified that they had a seizure in the past? The people who never had a seizure, you said non-exposed. Are you sure they really didn't have? Is it recorded somewhere? And finally, the outcome was a recurrent seizure. Are you sure you followed up everybody in both groups to accurately say in the same way that they had or didn't have seizure? So it's very difficult in India because our documentations are poor. Maybe in some European countries where everything is, every sneeze and cough is documented, you can do that. So all these are the different aspects of cohort study. In RCT, we tend to actively follow up people. But there are some RCTs with, like, I don't know what Dr. Salim studies, all people are followed up monthly for mortality or yearly, or through the database.
No, most of them are followed, but every 6 months.
But they're actively followed up. But suppose we say that in the US, you're going to look at the health system database for death for a large cohort. And we say that 99% of deaths are registered in the health system database. In India, we say we'll follow up 1 lakh people and we'll look at the deaths registry. 99% of deaths are not registered. Then the whole study has gone flat. So those are the kind of risk of bias in the cohort study. Nice, that's a good question. Methodological reviews. Now, as Dr. Khan said, some people say, why are you doing yearly RCT workshop? Every year we are learning a lot of things. You know, we were joking at lunchtime. We are learning more than all of you put together from Dr. Khan. Every year things are going on, you know, AI and RCT, so many things, adaptive trials. Like that, methodology of systematic reviews also constantly evolving. And there's a separate group called the Cochrane Methods Group. Here we go, AI in RC. So can you imagine doing a search using AI? Why not? Can you extract data using AI? Can you do risk of bias using AI? Can you do the whole meta-analysis using AI? You can. Only thing is they're not come to maturity yet. So you may get some totally garbage output. But it's there. Maybe in a year's time, we'll be laughing that we laughed at it earlier. But right now, they're not mature and ready. Okay, so what are the other methods? If anybody are statisticians, you can listen to this. If you want to do comparing multiple interventions, the Campbell Economic Group, Equity Group, now increasingly important, equity. If you're going to advocate a new intervention, what is the equity implication? Of course, Trump will have a seizure if he hears the word. Luckily, they didn't say diversity, equity, and inclusion group. Then the group would have been thrown out of yours. IPD meta-analysis, I'm going to talk about. Grade has come for RCT. Now there's grade methods for everything on earth. Non-randomized studies for intervention are cohort studies where one group gets an intervention, other group doesn't get the intervention, except they were not randomized. It just so happened that somebody took one and didn't come. The other things are priority setting, quality improvement, diagnostic methods, rapid methods. The statistical methods also are keeping on evolving. So these are very important because there are so many new types of data coming up all the time. How do you combine those data properly? So statistical methods are also constantly evolving. Now qualitative. So one of the big questions in general medicine is, should we do general checkup? Half the patients in medicine will come, what do you come? I want general checkup. According to Cochrane review, general checkups are useless. There's no value in patients going for general checkup. But in India, the most fastest growing healthcare service provider is general checkup, executive master health checkup, premenopausal, postmenopausal, young, old, whatever. Like, they'll put all sorts of masala and say this complete, incomplete, halfway, full way checkups. So, what are the factors which influence whether people go for general checkup or not? Why do some people go for general checkup? Why don't some people go? If you have insurance, if you don't have, why not we ask some patients? That is qualitative research. And if you have combined many qualitative studies together, qualitative systematic review. So one of the things they said, according to clients, first of all, being aware of the purpose of the general checkup or its existence. Secondly, asking them for their risk assessment, their understanding of their risk. Some people think I'm very healthy, nothing will happen to me. Some other people are very worried. Every ache and pain, they'll be at a doctor. So I'm just trying to give you that you can do systematic review of qualitative studies and it can influence your practice. If you understand why people think something, then you can make a behavioral intervention to change that. What is nudge? RCTs for nudge. We didn't discuss that. Nudge is slight behavior change. So instead of keeping only sweets there at tea time, we have a healthy fruit sitting there. We don't say anything, but we're nudging you towards like, put up a, fruits are good for you. So making slight behavioral changes, like nudging you towards going to one way. So qualitative research can lead to behavioral interventions also. So qualitative research also one of the beginning parts for intervention studies. Okay. Systematic reviews can be narrow. Can I go on a little more? Stop. Okay, another 15 minutes, guys. Sorry. They can be narrow questions or broad. Treatments for typhoid, narrow or broad? There are thousands of treatments. Ofloxacin versus levofloxacin for multi-drug resistant typhoid. Narrow question. So instead of looking at the slides, which is better? If you're a policy maker, what do you want? Because you want to know every treatment. You don't want to look at 20 systematic reviews and then come up with the policy. If you are a patient or a doctor wondering whether to give ofloxacin, narrow. So you have to choose. If one of you after this talk decides I want to do systematic review, what will you choose? Start with narrow. A single question, PICO, very easy. No difficulty in doing the study. If you start with broad, you'll have 15 or 16 different comparisons, very gargantuan systematic review, and you'll never complete it. Then you will curse me like. So do a narrow question. Okay, so we're not going to go into the broad and narrow. Okay. So the first thing, make your PICO and study design. You're not doing a study. For this PICO, study design. I showed you that levels of evidence, right? Second, register your title. Everybody and his uncle is doing systematic review, so you have to do it before somebody else does it on the same topic. Prospero will tell you, sorry, there's already somebody registered in this. Open Science Foundation will not. So many people use that backdoor. I also want to do and put it in OSF. Cochrane will only register titles which they think have a public health impact. You may be very convinced about your interventions review or qualitative review, but unless the Cochrane editorial board believes it has a policy impact globally, what is global? Global. globally beneficial, but also locally relevant. Very often people from India will say 3 months versus 6 months anti-TB regimen for South Indian patients with TB. How can South Indian patient be different from North Indian, from East and West Indian? No. How are we different from Nepalese or Bangladesh? No. Pakistani? No. So we should not write systematic reviews which answer a question only for me and my uncle and auntie. It has to be a globally relevant question which is locally applicable. So local. So I'm saying everybody wants to do systematic review for me like that. Answer this question. It's a waste of your time. It takes 1 year to do a systematic review. On average, about 5 to 6 people who spend at least 2 hours a day. A lot of work. So you must do globally relevant. Plan the review. What is planning? Protocol. Human resource, HR. So I was talking about HR in his department at lunch. So then you have to say, Dr. Kant and Dr. J will be the people who are going to screen the abstract. Dr. Vishali, I don't know your name. Anya. So we'll say Dr. LJ and Dr. VIP, SIB are going to do the, VIP. Dr. SIB will do the abstract screening. Initials so-and-so are going to do full text screening. Your two initials are going to do the data extraction. These two people initials are going to do risk of bias assessment. And so-and-so is a statistician, he's going to do. And then you know that the person doing the statistical analysis knows that, hey, it's going to take 3 to 4 months before this whole process finishes. So he's got his time ready. He can be in any country in the world. You can work across time zones as long as you know. And then there should be one tyrant at the top directing affairs. Suppose usually the junior most person will be put, oh, you do the review and all of us will help you. Then he'll be like, sir, please finish the extraction tomorrow. Then, instead of two people independently doing data extraction, the two people sit together and do data extraction. No, that's not the correct method. So I'm just telling you the pitfalls of doing a systematic review of 4 friends together. Doing independently often suffers. Publish your protocol first. Can you do an RCT without CTRI number? You can send it to it takes 3 months for them to respond, no? Indian Standard Time. It's okay. I like you. CTRI suddenly became quick. I don't know how you made it quick. Same thing. You have to publish your protocol, then only start searching for literature. Publish your review. Do you have to update the review? How often? So you know your own specialty. If, for example, COVID, studies were coming every week, then you have to update your review practically every week. If in your specialty, they don't come once in 2 years even, minimum once in 2 years. And go through the whole process again. Do you have to just search for that extra 2-year period or do they rerun the whole search? Generally, you rerun the whole search. So more than one person, an information specialist and methodologist, you need time, you need money, you need office tools, which I'll talk about, access to literature. Any young people? Who are the young people? Who feels young? Younger than me. Madam, have you heard of Sci-Hub? What? I never heard of Sci-Hub. Can we do Sci-Hub? Now everybody's like, what? I'm not young. I don't know what you're talking about. This is a Russian site where you can put in any journal article and you get it for free. Any article or any textbook. Yes. So what will happen in your search? You will find 10 articles, full text, which you want to include. Can you go to Sci-Hub and download them? No, can you go to Sci-Hub? So I didn't do randomization. I'll just say I did it. I didn't do allocation concealment, but I'll write it. So the truth is you cannot. So what you have to do is write that the following articles were paid articles and we could not access them. Usually the articles from European countries which are in Embase, to search Embase, you have to pay money. That's why most of us don't search Embase. We all search only PubMed. But there's a backdoor to that. Cochrane has a group of librarians with paid access to Embase. If you search Cochrane library, it'll give the search results by, these are the PubMed searches of RCTs from PubMed. These are the RCTs separate, came from Embase. These are the RCTs which came from WHO database. These are the ongoing trials going on. And it clearly mentions in all groups, articles which you don't have access to, please don't get in any pirated methodology. Just say those are not available for me, right? But some people will say you didn't do M-based search. We don't agree. It's better to do that than to get it through some, I should not be telling you all the methods how you can do that. The software is called RevMan, which is paid. Ryan is a free software. But if you do a large review, multi-center, many people, you have to pay for it. If you're planning to do systematic review all your life, you love this, and you have a group of experts around the world, there's a fantastic software called Distiller. We all used the Distiller software recently. Very good. You can search studies, you can extract data, you can create drafts, everything in that. Then this Joanna Briggs has got a software. Our software is excellent, but you have to know how to do. It's a big steep learning curve to learn R. And there's another one called Epi Reviewer. These are the software which are required. Now, oops, this is not projecting well. The RevMan tool is an excellent tool. And we run workshops every 3 months. If anybody's interested, you can attend those. Okay, I'm going to the last 10 minutes. Is it okay? It's a bit late. Okay, network meta-analysis. Okay, has anybody taken a painkiller for backache, knee pain? What did you take? You never had pain. Paracetamol, diclofenac, ma'am. Paracetamol. Anybody else? Combiflam, which is best? But now there are more than 3 drugs, no? How will you do systematic review? The back pain, you are comparing Combiflam with paracetamol. She took aceclofenac. But we have one RCT comparing aceclofenac with paracetamol. We have an RCT aceclofenac with diclofenac. Aceclofenac with Combiflam. How will we know which is best? So when you have more than 2 comparisons for the same condition, we have to do something called network meta-analysis. The basic part is you must have more than 3 comparisons. In the interest of time, I'll explain more through pictures than from text. Okay. This is drug A, this is drug B, drug C, drug D. 2 lines means there were 2 RCTs comparing A and B. A single line means 1. This is the basic structure of what is called a network diagram for the same condition. Correct? Suppose there is no study comparing D and B, it will be left blank. Okay? Who likes maths? Now everybody suddenly like, yes, sir. Can you tell me how to compare A and C? You said you like maths. Barney's ace in trigonometry. If you know 2 sides of a triangle, can you calculate the third arm of a triangle? So tell me, how can you get A to C? No, she has to tell.
I don't know the exact thing, but they tell me something.
So A to C has to be 1 arm of the triangle. Which is the other 2 arms of the triangle? Between A and D, B and C, one can estimate what is likely to be this. What about A and B, B and C? Again, we can estimate. Whenever you see a black line, it is called direct estimate. Where they're not shown, where you can put a dotted line, is called a indirect estimate. So that's how the advantage of having a network meta-analysis. Even if there is no comparison between 2 drugs, if you can draw a triangle of the other drugs, sometimes you will find there's a drug E which is sitting somewhere here, B to E, and it's nowhere. Then you cannot do a network indirect effect from that, though there are some Bayesian methods where one can do that, and we'll talk briefly about that. Okay, so for an example, for smoking cessation, there's for weight loss, don't eat gulab jamun at lunchtime. Dietitian, doctor, nurse. What is this? Randomized control study, dietitian versus doctor. Randomized control study, dietitian with nurse. What is this? There was no randomized control study comparing doctor with nurse. We can get that from network meta-analysis. You can even have 4 comparisons where one arm is a indirect estimate. So the now added pharmacist as well. Everybody clear? Direct effect is when there's a direct randomized control study. Indirect effect is when you make it from the rule of trigonometry or maths. Yeah. It's mathematics. Mathematics is a correct, exact science. So don't worry. All right. We'll come to that. Your question is very relevant. I'll answer it in a little while. It's a very correct question. Okay, here's an example from psychiatry. This person came to Vellore and taught us actually. Her name is Georgia Salanti, and she taught us how to do network meta-analysis. So just the next campus from here is called the mental health campus. And you'll find sometimes rarely manic patients running around like, I mean, don't be scared, like, you guys are purposely exposing us to manic patients. So there are 68 randomized control studies involving so many comparisons in mania. How will you do? You can do 68 separate systematic reviews, or one can do a network meta-analysis. So first, you must list out all the drugs. First part. Then you may say, oh, I got more than 60 RCTs, totally 16,000 patients. Next. So each study is going to give a summary statistic, odds ratio, relative risk. We are not combining the data from all studies, only the summary statistic across the studies, and we are going to combine these. Just remember that. Now you make the network diagram. These are the various drugs for mania. Only the direct comparisons are shown in the picture. Placebo was a very common one. Why is this line slightly darker than this line? More studies. So placebo versus risperidone seem to be the highest number of, and the size of this means lot of studies comparing that, this node. Because placebo didn't put a node, but risperidone seemed to be one with the, these are called nodes. And the strength of the line or the width of the line represents the number of studies in that particular comparison. Okay? No, not strength of us, number of studies. This is called network diagram. Now, remember that between haloperidol and placebo, there are many studies. Not many patients, many studies. And like I taught you earlier, systematic review, we meta-analyze those studies. We combine all the odds ratio or relative risk or risk difference, or if it's a continuous outcome, mean difference or standardized mean difference, we meta-analyze this. Then quetiapine versus placebo, we meta-analyze this separately. Then we estimate the indirect effect of haloperidol with quetiapine. Correct? Then, oh, there are more drugs. So now can you tell me H to Q, somebody else who's not answered? Plastic surgeon will have to tell us. How can you get H to Q? Tell me 2, 3 triangles. A, H, A, Q, H, P, H, B, Q. So this indirect effect is combining all of them together. That's the strength of the network. It's not just one indirect. You can get it from many and you put them all together. How you mathematically do, we don't have to worry today, but this is the indirect effect. Everybody okay? Okay, now here comes the good news. Seeing this, Vineet decides, I don't believe in indirect effects. I'm going to do a randomized control study with haloperidol and quetiapine. That is now become a direct effect. Now, can I combine these two effects together? Yes, one can combine the direct with the indirect effect, and that is called network effect. Should they be same, direct and indirect effects? Ideally, direct and indirect effects should be similar. So this is the network or mixed treatment effect. We'll come to that. So do you understand now? Some people call it mixed treatment effect or mixed treatment meta-analysis, the same as network meta-analysis. Network meta-analysis doesn't do one by one. All simultaneously are done by the software. Okay. The large line represents large number of studies. The big size represents bigger node, more comparisons with that one. Now, you remember the risk of bias from earlier? For that comparison between placebo and ziprasidone, good quality studies with low risk of bias, whereas placebo versus haloperidol, very large number of studies, thick line, but high risk of bias. So now we can incorporate risk of bias into a network diagram and give more information from a network diagram. But because there are many software and many groups doing network, some will put the color, some will not put the color, some will show indirect dots also, some will only show the direct comparisons. Okay. How many like movies? So cinema stands for confidence in network meta-analysis. Like Madam was expressing, hey, I'm not very confident of this triangle and doing mathematics and doing all that. So there is a methodology for doing risk of bias in network meta-analysis. It's called cinema. I mean, they just very cleverly got the word cinema, confidence in network meta-analysis. And there's a nice article which is published by Salanti and colleagues here. You can read that. And there's a software. You can go to the website, and this is the website, cinema.ispm.unib.ch. This is how the cinema picture looks. This is, let's just take one. CCTA is one sort of intervention and CMR is one intervention. For that particular comparison, each of this is one study. So there were many studies of low quality, of good quality. Some studies have ambiguous quality and many studies of higher risk of bias. So for each comparison, you can get breakdown of the risk of bias for that particular comparison. We cannot go into time today how to develop a cinema plot, but you can read about it. All these are freely available. How many of you like IPL? This is like a league table for IPL. So let's just have a look. Haloperidol stands for, HAL is haloperidol. This is risperidone. So if you want to know the effect of haloperidol versus risperidone, look at this particular square. So that's how one interprets this graph. So this is also sometimes a league table or different words people use. So this is for each comparison you can do like that. They put efficacy in blue and they put the dropout rate in white. Some people will show the direct effects below this line and the indirect effects on this. Then you can compare and see, hey, the direct and indirect are both saying the same thing, I'm happy. In this particular graph, they're not done like that. They've chosen to show the dark blue as the efficacy outcome and the dropout rates in the top. So you can look at, it's an efficacious drug, but the dropout may be high. So that's how they have given in this particular figure. This is another way of presenting the evidence. For the same story, they have taken fluoxetine as a reference drug. Compared to that, the network effect. This confidence interval is a network effect. Escitalopram seems to be slightly better, whereas reboxetine seems to be doing slightly worse. So you can compare the treatments in a network meta-analysis and see which is likely to be better, which is likely to be equal to the placebo, or which is likely to be worse. So you can ask different NSAIDs, comparing between them which is better. So we can do in a network meta-analysis. Now, to make it a little more complicated, ranking. You know, I think only India from LKG till you finish, like till you die, you will be ranked like first rank, second rank, third rank. That we are obsessed with that. But in network meta-analysis, they give the probability of ranking. So just spend 30 seconds looking at the picture. Which is the treatment most probable to be ranked 1? This is the ranking, rank number 1, 2, 3, 4. These are the drugs. So you can see erlotinib has 85% chance of being ranked number 1, 10% chance of being 2, 4% 3, 2% and 0% chance of being least effective. So this is also called table of ranks. Obviously, placebo will have the highest chance of being ranked worst. I mean, some drugs may be worse than placebo also. They can actually cause more harm than good. So that's also possible. So these are the competing treatments which from a network. Some people also call it bubble plot. I mean, different words for this. Questions? Now, some people like the same thing to be shown as a graph. So let's look at where is erlotinib? Or let's look at, one second. Okay, look at sertraline. Okay, that dark line. What is the probability of it being ranked for? 30%. What about escitalopram? Rank 1, there's about 30% chance it is ranked 1. So this is also called a rankogram. This uses the Bayesian little bit to give the ranking, pre-test probability married with the current evidence to give the post-test probability, but we won't go into that. So this is rankogram showing you the same thing. Be careful. Sometimes when there's less evidence, the amount of information is low in the network, ranks don't work so well. So don't sell your soul and say that network said this is the number 1 treatment. Read more about it and see if that's really what you see. As always, look at the effect size. What is the point estimate? What's the confidence interval? And then you make your decision. Now, madam's question. When you randomize, why do you randomize? Baseline characteristics should be equal. In a systematic review of drug A versus B, are the baseline equal for all the studies? You hope so, because you have carefully chosen PICO. You're not comparing studies of children, adults, and geriatrics in one systematic review. Similarly, mentally, you must imagine all the studies in the network meta-analysis came from one imaginary large same population. All of them could have been randomized to any intervention or control, and the outcome should have been measured in the same way. And that assumption is called transitivity assumption. It's a mental assumption which you look at the baseline characteristics, inclusion, exclusion, then you say transitivity assumption has been present or not. So it's also, some people use the word jointly randomizable. So one can imagine if you have 5 drugs in a network, what would be the imagination? One large trial with 5 arms. And the baseline characteristics are same, the interventions are different, and the outcome is measured same. That is jointly randomizable. It's a concept, transitivity assumption. How do you test it? Simple way. The direct estimate should be close to the indirect estimates. That's one simple way of doing that. I'll show you another table called inconsistency assessment. We won't go into interpretation of that. That takes the transitivity assumption. So for example, looking at A and B for cancer, stage 1 patients, stage 1 patients, stage 1 patients. These are stage 2 patients. Can I do the network assessment here, indirect assessment? No, because these are stage 2, this is stage 1. This is just a picture to show that you should be very careful when doing network meta-analysis. The question you asked, ma'am, is very vital. Transitivity assumption should be there. And if you've got 30 or 40 drugs in a network, how are you going to make sure this is there? It's quite a mind-boggling prospect. This is the incoherence factor which assesses whether the direct estimate, indirect estimate, then it combines the two and produces an incoherence factor which assesses whether there is transitivity assumption is held or not held. Now I'm going to make you all do some work. Have you heard of living systematic reviews? During COVID, every week or twice a week, a new randomized control study was being published. So people said, you have to do systematic review updated every week. And this was done by a group of people and was published first in BMJ 2020. And every week or month, it used to be updated and published in the BMJ. The last one was 14th July 2022. There were 278 studies, 1 lakh participants, which included 96 preprints, unpublished literature, and they said, based on looking at CTRI, not Indian CTRI, the Indian International Clinical Trial Registry, there are 43 trials coming up with another 5,000 patients, which should be included in the next weeks or the next month or whenever they are published, updated systematic review. Because it's being done practically every day, it's called a live systematic review. You think few people will do the work? A lot of people? A lot of people. So the main author was this Reed Semenyuk, my pronunciation may be wrong, Semenyuk, and Dr. Gordon Guide. I don't know whether he's in McMaster still.
Oh, yeah, he's still there.
So Dr. Gordon Guide is a famous epidemiologist, so we all know famous people.
The head statistician was Jessica Bartowska.
Oh, okay.
She was a PhD student to this.
Okay. So this is a lot of work by a lot of people to produce one living systematic review. So this is how the data looked. There are many outcomes, right? COVID outcomes were long COVID, death, morbidity, quality of life. So first you must specify what was the outcome. Here the outcome was mortality. This is a network or this is a simple systematic review? Network. What are these? Nodes. And the dark line, the bigger the line, more studies. Here they put a color. All those in green had benefit for mortality. Everything else, these were questionable mortality benefit. These had significant concerns and should not be used. The only thing which should be used first was corticosteroids. The second one was IL-6 receptor antagonist, and the third was Janus kinase inhibitors. So they have produced a picture like that. So this is how a living, sorry? Okay, that's, you can put the number of patients could be there. What they put is higher quality evidence and lower quality evidence. So when you have these hashed lines in between. Yeah. Anyway, so just another thing which we didn't mention, that a picture tells 1,000 words. All RCTs now, people like to produce these beautiful one slide, summary slide. And they use, I don't know what software they use. We had one, I've forgotten. You can make, there's software available where you put in the data and it'll produce a beautiful picture for a one picture infographic of the whole RCT. So this picture will tell 1,000 words, like people who don't understand, so those are good, these are not so good, right? Okay, and then this is how some statisticians said that's not enough. We want more data on mortality. How many people will die per 1,000 if you don't take any medicine with COVID? At the height of wave 2, 130 people died per 1,000. And then they said the minimal important difference, policy makers said, if it reduces that by 10, then WHO, CDC, NIH would recommend the drug. So for glucocorticoids, the number was -23. That means the death will come down from 130 -23. So about 107. That could range from -40 to -7. Right? So that's how the work went on. Every week this picture, or every 2-3 weeks this picture will be. The last one is individual patient meta-analysis. Here what happened, from each study, you write to the author, give me all your data. Not just the summary, odds ratio, relative risk, the age, sex, gender, intervention, outcome, everything you give. These tend to be smaller because most authors will not share all the data. They want to publish one more paper. They're not sure who is this guy writing and asking, or you're worried that your data may be exposed for fraud, for fraudity, not fraudity, I mean for fakery, fraudity, whatever you want to call. So you don't have too many large IPD meta-analysis. IPD stands for individual patient data meta-analysis. So this is one. Aspirin after percutaneous intervention, whether you can stop aspirin or continue aspirin or P2Y inhibitors. So they did the same thing. 984 studies were looked at in electronic database. Finally, only 5 studies were included. Because only 5 studies, they got all the data. It's not just the summary. All the data has to come. The same thing, randomization, allocation, blah, 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 overall risk of bias for all those 5 studies. And finally, there's a baseline characteristic table. How baseline? You combine all the 5 studies like one giant study. So you have a baseline characteristic table. Can you provide hazard ratios and can you do survival analysis? Yes, you can because you got the same data. And you can also do each study individually and you can produce a forest plot as well. So just to say, complete this picture that one can also do individual patient data meta-analysis. Now I want you all to open this website. Earn your coffee. COVID NMA. COVIDNMA.com. Website is internet. Sorry, I'm making you doing something. Okay, I've come to the website. Sorry. You all come to this website. Now I want you to go down. There is this place which is called treatments. You can see a treatments. Click on treatments. And I want you to come down. Did you come to this website? Can you come down? You'll see one thing called forest plots. Yes? Did I miss anybody? I'm going a bit fast because it's supposed to be a coffee break. Forest plots. Did you come to this website? Hey, where did that go now? I have missed the site. Site has jumped. Okay, sorry, just before, you can just go to this forest plots, put the name of your drug, dexamethasone. Just put dexamethasone. and then you click forest plot. On the left-hand side, you'll find COVID-19 treatments. Here. Everybody came to that? Right? Now you select a treatment, just choose dexamethasone. There are many options for dexamethasone. We'll just choose the second one, corticosteroid was a standard of care. Everybody choose that. Enter. Now, what is the outcome of interest? Yesterday we were discussing how can a drug affect 90 days mortality? What is more equal? 28 days. So here's an outcome for 28-day mortality. Mortality D28. Correct? Now, the next question. All populations, people mildly sick, moderately sick, critically ill. For the sake of argument, we'll put all populations. Okay? Did I miss anybody? You want random effects or fixed effects? We'll keep it as random effects. And then you can choose the methodology. I didn't talk about this methodology of doing confidence interval. This is also a new one. Simonian lab is an older one. There's now actually Cedric Jointman. There are 4 people. I forgot the other 2 authors' names. So it's not this SJ, it's some GS methodology. This is a flavor of the season now. But we just keep it as restricted. Then the next question to ask yourself, you want a subgroup by severity or conflict or funding? You can choose. You want to do a sensitivity analysis by high risk of bias? You want to include preprint or exclude preprint? And you want to hide some population severity? So just given there. Okay? Now you go down. Can you see? Okay, now I want somebody else to do some hard work. How many studies are there? So there are about 14 studies. What is the overall I-square? Okay, I-square is 0.0 something. Is it a random effect or fixed effect? You can see tau square here. Right. You can see that this is a mixed population and this is a critically ill population. What is the effect of, can somebody tell me, what is the effect of steroids in mixed population? 0.91, 0.842, 0.98. It doesn't touch the, one means no difference. Are you an optimist or a pessimist? What, Job? If you're a pessimist, you'll say that there may be only 2% change in mortality. Optimist will take 16% difference in mortality. Policymaker will probably choose that at worst I may get only 2% improvement in mortality. With 2% improvement in mortality, will you take steroid or give your father, mother, uncle, aunt steroid? Is 2% meaningless for mortality? Many people say even 1% decrease in mortality is worth it. Steroid is a relatively harmless short-term drug. What about the quality of the evidence? Randomization, allocation, blinding. Overall reasonable quality of evidence. What about for the critically ill people? Dexamethasone, confidence interval is crossing 1 and not showing much benefit. But people didn't see this. Every sick person in the ICU was being given dexamethasone. Why? It's working on some other people. It's okay, let me take it, nothing will happen. The policy sometimes may not exactly match the evidence. So all of you have now done a living network meta-analysis yourself. I think that was my last slide. Okay, the last point I just wanted to make is called FAME, F-A-M-E. Now people are saying, let's say in McMaster, they are doing a large randomized control study of 2 interventions, and they realize that there's a bigger, another large RCT being done in, let's say, UK, and a third large one in India. Not the same multi-center, but 3 different. When they finish, they can contact the other 2 groups and say, guys, as soon as you're ready, shall we do a meta-analysis of all 3 studies? However, the way you have coded the data is quite different from the way we have coded the data. The outcomes you are capturing for even MACE, our MACE is death, all-cause mortality, cardiovascular mortality, and stroke. But you don't have stroke, you have got heart failure hospitalization. Can we agree on a common set of minimum outcomes and minimum data which can be shared? So the day the 3rd study is over, we'll already have published alongside with it a meta-analysis. This is called FAME. I forgot the abbreviation of FAME. Some framework for, and so meta-analysis, framework for something meta-analysis. So if you agree to that, and if you're part of a large trial, you can tell the group, yes, I'm willing to share my data as soon as my study is over, and all the studies would have been collected in the same way, and the meta-analysis will be ready for publication. Same drug, same comparison, but more important, everything else is similar so that the data can be combined together easily, fast. Otherwise, we must collect the data separately, clean the data separately, make sure everything lines up, all the graphs can be done. Yeah, because everything has been prospectively planned. Though separately planned, you can plan that this information will be similar across the studies. I mean, the headings will be similar, the way it's collected, everything is similar, so we can directly do the analysis.
So Salim did this with the polypill.
The polypill, yes, yep.
We talked to the person in Iran that was doing it, and let's plan this, so when your study is finished, we can do a meta-analysis. Individual patient data.
Yes. So IPD meta-analysis, I was saying about a polycap study. You can just Google that FAME systematic review, you'll get that answer for that. Any questions?